In this video we will discuss beta thalassemia. So beta thalassemia is a group of hereditary hemolytic anemias characterized by a genetic deficiency in the synthesis of beta globin chains. This imbalance or decreased beta globin chain synthesis leads to two primary pathological consequences. One is reduced hemoglobin production causing microcytic and hypochromic anemia, and the accumulation of the unpaired alpha globin chains which precipitate and destroy the red cell precursor in bone marrow and in the spleen. As we know, adult hemoglobin HbA is composed of 2 alpha and 2 beta globin chains. Thalassemia is commonly found in Mediterranean, African area, Southeast Asia. Gene for beta globin chain are present on chromosome 11, and genes that coded alpha globin chains are present on chromosome 16. There are two other type of hemoglobin that we will discuss, or they play an important role to understand beta thalassemia. One is HbA2. In HbA2, alpha 2 and delta 2 globulin chains are present. In HbF, alpha 2 and gamma 2 globulin chains are present. Now we will see the molecular pathogenesis of beta thalassemia. The primary defect is reduced or absent synthesis of the beta globin chains. There are two types of genotypes that we are going to use again and again. Beta 0, this signifies total absence of beta globin, and beta plus, this signifies the reduced but detectable beta globins. Key mutation in beta thalassemia is point mutation. This is the most common cause of beta thalassemia pathogenesis, unlike alpha thalassemia, which is usually caused by gene deletion. So there are three types of point mutation: splicing mutation, chain terminator, nonsense or frame shift mutation, and third is promoter mutation. So in splicing mutation is most commonly caused beta plus type of genotype. Chain terminator mutation is the most common cause of beta 0 type of genotype, and promoter mutation they seen in beta plus type of genotype. Beta thalassemia or thalassemia is an autosomal recessive disease. Pathophysiology of beta thalassemia, or the twofold anemia is seen in beta thalassemia. As we know, in beta thalassemia there is decrease or no synthesis of the beta globin chain. If beta globin chain is decreased or absent, there is decreased production of the adult hemoglobin or HbA, and there will be anemia. Mainly microcytic hypochromic anemia seen in beta thalassemia. The other mechanism is due to decreased beta chain, there is increased alpha or unpaired alpha globin chain is there. They form an aggregate which is insoluble and cause damage to the RBC or RBC precursors by various mechanisms, primarily by the membrane damage, and this increases the apoptosis of RBC precursors, and some damaged RBCs are destroyed in the spleen, resulting to extravascular hemolysis. So both of these mechanisms result into an anemia. Now, as we have discussed the pathophysiology, which is depicted in this diagram, alpha is normal and beta chain is reduced or absent. So Impaired beta globin synthesis will result into decreased HbA synthesis and development of microcytic hypochromic anemia. Another mechanism is unpaired alpha globin chains causes damage to the RBC membrane or red blood cell precursors in the bone marrow. Damage to these precursors promotes the apoptosis, and this will result into the compensatory erythroid hyperplasia into the bone marrow. Due to this erythroid hyperplasia, there is increased secretion of erythroferron, which is secreted by RBC precursors. This erythroferron decreases hepcidin, and low hepcidin level will result into increased iron absorption. As the alpha globin aggregates causes damage to RBC or precursors, this also causes anemia. And to compensate the anemia, there is extramedullary hematopoiesis. And as we have already said, these damaged RBC, when travel through the spleen, are phagocytosed by the macrophages and result into the hemolytic anemia, extravascular hemolysis. So iron overload we will discuss into the complication. The clinical features are the typical clinical features of the anemia: pallor, weakness. As this is hemolytic anemia, jaundice can be seen, icterus can be seen. Now we have two types of beta thalassemia to discuss: beta thalassemia major and beta thalassemia minor or trait. Genotype of beta thalassemia major is homozygous beta 0 or homozygous beta plus or double heterozygous beta plus or beta 0. In beta thalassemia minor, one beta globin gene is normal and other can be deficient or completely absent. Beta 0 or beta plus heterozygous. Beta thalassemia major is a severe transfusion dependent condition, and in beta thalassemia minor, mostly patients are asymptomatic, and this is an incidental finding most of the time. Beta thalassemia minor. On HB electrophoresis or HPLC, there is increased HbF level in beta thalassemia major, mostly more than 90%. The primary hemoglobin is HbF in beta thalassemia major, but in beta thalassemia minor, HbA2 is seen in the range of 4 to 9 or 4 to 8% with normal or slightly increased HbF. Clinical onset of symptoms is after 6 to 9 months in beta thalassemia major, and as we have already said, beta thalassemia minor or trait is an incidental finding, mostly asymptomatic. Beta thalassemia intermedia is holding the middle ground in the severity between beta thalassemia minor and major. Interestingly, if the co-inheritance of alpha thalassemia is present with beta thalassemia, this improves the symptom by reducing the chain imbalance. Beta decrease, alpha decrease, so there is no or low alpha aggregates, so there is no damage to the RBC membrane. Now we will see the morphological and radiographic findings in beta thalassemia. Primary cell type is microcytic hypochromic cells. Microcytic hypochromic cells along with the basophilic stippling, target cells, microcytes, and variation in size and shape of the cell, which is known as anisopoikilocytosis. In the case of beta thalassemia major, there is excessive erythroid hyperplasia may result into the presence of normoblast in peripheral blood. On X-ray, due to massive marrow expansion, the marrow erode the cortex and result into the crew-cut appearance on the skull bone. So these hair-like projections, we can see. This is known as crew-cut appearance on skull X-ray because of the massive marrow expansion that erode the cortex. As the anemia promotes extramedullary erythropoiesis, this will result into the hepatosplenomegaly. Now we will see the diagnostic approach to beta thalassemia. Patient present with the clinical symptoms of anemia on complete blood count, so microcytic hypochromic anemia with low RBC indices, MCB, MCH. On peripheral ischemia, there are target cells, basophilic stippling, anisopoikilocytosis, normoblast, and polychromasia. Now, our main two differential diagnoses are beta thalassemia and iron deficiency anemia. On HPLC or hemoglobin electrophoresis, in normal individual or in iron deficiency anemia, there is HbA is around 98% or 95%. HbA2 is somewhere between 2 to 3.5% and HbF is up to 2%. But in case of the beta thalassemia minor, HbA2 is between 4 to 8%, and in beta thalassemia major, which has more severe clinical symptoms, and this patient is particularly transfusion dependent, showing HbF around 95% in HPLC graph. Difference between thalassemia minor and iron deficiency we will discuss later. Molecular genetics also play an important role in prenatal diagnosis and to identify the specific mutation in beta thalassemia. Okay, now we see the various HPLC graph. HPLC is a better technique than a more advanced technique than hemoglobin electrophoresis. So this is the normal graph of a healthy individual. We need four things to read an HPLC graph, or these are the prerequisite to read an HPLC graph. Baseline supposed to be properly constructed. Second thing is A2 peak. This is the A2 peak. A2 peak should be present. P3 value is less than 8%. More than 8% P3 value indicates contamination of sample. Area or total area is between 1 to 4 million. So this is the HPLC graph of normal individual. Now we will see the HPLC graph of beta thalassemia trait. This is showing A2 value 4.9%, and most of the hemoglobin is HbA around 83%. So HbA2 value 4.9 with a normal HbF is suggestive of thalassemia trait. In thalassemia major, the main hemoglobin is HbF, and in thalassemia intermedia there is increase HbA2 4.7% and HbF is 25%. So in beta thalassemia intermedia there is increased HbA2 between 4 to 9%, and HbF is also raised somewhere between 10 to 30%. Now we'll see the complication of thalassemia, beta thalassemia. Iron overload is the very common and severe complication of beta thalassemia, and there are two mechanisms by which there is iron overload in beta thalassemia. The first is, as the decreased synthesis of beta chain will result into decreased hemoglobin. This causes anemia, and to treat this anemia, patient require chronic or repeated transfusion. This will result into iron overload. And the other mechanism is, as we have discussed, there is erythroid hyperplasia in beta thalassemia. So in erythroid hyperplasia, there is increased erythroid precursor. They release erythroferron, which decreases the hepcidin and result into the increased absorption of iron from the gut and causes iron overload. This iron overload is known as secondary hemochromatosis, and this secondary hemochromatosis causes damage to heart, which is the most common cause of death in beta thalassemia. This secondary hemochromatosis may involve liver and pancreas. Now we will see the difference between thalassemia minor or thalassemia trait and iron deficiency anemia. Thalassemia minor is also known as thalassemia trait. So on morphology, both of them are showing microcytosis, hypochromia, target cells can be seen in both the condition. But in iron deficiency anemia, there are pencil cells, annulocytes, and in beta thalassemia there is basophilic stippling, which is usually not seen in iron deficiency anemia. Polychromasia is there, and sometimes nucleated RBC can be seen in thalassemia trait. So on complete blood count, hemoglobin is decreased in both the condition, and RBC count is decreased in iron deficiency anemia, but in beta thalassemia RBC count is increased, which is disproportionate to the level of HB. RBC count is unusually high in beta thalassemia trait or beta thalassemia because this is an hemolytic anemia. This is a hemolytic anemia, and due to hemolysis, bone marrow produces more and more RBC. So count is usually normal or increased in thalassemia. MCS is decreased in both the condition, and there is RDW is particularly high in iron deficiency anemia, means there is wide variation in the size and shape of the RBCs. RDW usually normal or slightly high in thalassemia trait. On biochemistry, ferritin, serum iron and ferritin is decreased in iron deficiency anemia. TIBC is increased in iron deficiency anemia. TIBC stands for total iron binding capacity. In thalassemia, ferritin is normal or iron is usually high because of the iron overload. On electrophoresis, thalassemia clearly shows, based on which type of thalassemia, whether it is minor, intermediate or major. There are peculiar HPLC finding like increased HbA2 or HbF. The main cause in iron deficiency anemia is depletion of the iron or decreased iron deficiency. And in beta thalassemia, as we know, this is an hemoglobinopathy due to decreased beta globin chain synthesis. Beta thalassemia require genetic counseling because this is an inherited disease. One important index is also known as Mentzer Index, calculated by MCV divided by RBC count. This is normally more than 13 in iron deficiency anemia and less than 13 in thalassemia minor. So what are the treatment options? We will not discuss detail about the treatment option, but as we know, thalassemia major need frequent transfusion. The frequent transfusion can result into the iron overload, so we need chelation, iron chelation, which is achieved by deferricerox, which is oral, or deferriprone, which can be given oral or in the form of injectable, and defuroxamine, which is an injectable liquid. Folic acid supplementation is also help in the management of beta thalassemia, as the folic acid promote synthesis of the new RBC. Hematopoietic stem cell transplantation is the curative option for the treatment, and in the newer modalities, gene therapy is there. Basically, this technique modifying the patient's stem cell to produce healthy hemoglobin. So there are two drugs, betiveglogene autemcel, also known as Zynteglo. This is an FDA approved drug for the transfusion dependent patient. FDA approved treatment option for the transfusion dependent patient, and the other one is hexagamglogene autotemcel, also known as Casgevy, a CRISPR based gene editing therapy usually advised for the patient 12-year or older. So this is brief about the treatment. Thank you for watching.